So we'll continue our discussion on newborn jaundice. So this is the part 2 of the continuation. In the first video, we looked at the basics of newborn jaundice, the pathophysiology, the bilirubin metabolism, and clinical history taking in a case of neonatal jaundice. In this video, which is the part 2, we'll emphasize on clinical examination, and then we'll continue this series with a part 3, where we'll discuss investigations, treatment, theory, discussion, and viva questions. So to quickly summarize what we discussed in the first video was at the end of history taking, we were able to summarize this as a case of either physiological or pathological jaundice and what the most probable etiology for the jaundice could have been. Okay, so once you say that this is either a case of physiological or a case of pathological jaundice, the first question that comes to mind is how do you differentiate the two? And when do you say that the jaundice is either physiological or pathological? So let's look at the difference between physiological and pathological jaundice. So if it's physiological, you will always see jaundice after the first 24 hours of life. Physiological jaundice usually peaks by about 3 to 5 days and disappears by 2 weeks in a term baby and 3 weeks in a preterm baby. Whereas if you're looking at pathological jaundice, any kind of jaundice clinically visible within the first 1 day, that's first 24 hours of life, will always be considered as pathological. If it's prolonged, that means if it persists for more than 2 weeks in a term baby or more than 3 weeks in a preterm baby, again, the jaundice is termed to be pathological jaundice. If there is a higher component of direct bilirubin, that means there is more conjugated bilirubin or your direct bilirubin. Again, looking at the values, if the direct bilirubin is more than 1 milligram per deciliter, when the total serum bilirubin is less than 5, or if the direct bilirubin is more than 20% of the total serum bilirubin, if the total serum bilirubin is more than 5 mg per deciliter. Okay. So what I'm trying to emphasize here on is that if there's a higher proportion of the direct bilirubin jaundice, then it's considered to be pathological. If the jaundice involves the palms and soles, that again means that it is severe jaundice and always considered to be pathological. So we look at why the palms and soles are involved and what do we mean by the Kramer staging in the following slides. But when there is jaundice, it always progresses from the cephalocaudal direction. So it starts with the head and spreads to the extremities. So when you have involvement of the palms and soles, that means the jaundice is severe enough, and then it would be considered as pathological. Then if there's a rapid rise in the bilirubin, so the rate of rise of bilirubin is more than 5 gram per deciliter per day, or more than 0.2 mg per deciliter per hour, then again, it points towards a pathological cause. If the total bilirubin is more than 95th percentile on the R-specific normograms. So we look at these charts that the AAP recommends now to decide whether the child requires phototherapy or not, or whether the child requires exchange transfusion or not. So if you look at the charts, when the bilirubin is more than 95th percentile is when the child will fall into the criteria of receiving phototherapy. So any bilirubin more than 95th percentile is always going to be considered as pathological. And along with these numbers, if clinically there are signs of vomiting, lethargy, poor feeding, excessive weight loss, apnea, seizures, temperature instability, etc., which points towards acute bilirubin encephalopathy, then again, that will always be considered as pathological. So this is how you differentiate your jaundice as whether it's physiological or pathological. Having said that, once you know how to differentiate the two, it's very important to understand what are causes of physiological jaundice and what are causes of pathological jaundice. So we have discussed this in detail in the first video. I'll just quickly go over this again. So physiological jaundice occurs either because of increased bilirubin production, decreased hepatic conjugation, or increased enterohepatic circulation. So newborns have a higher hemoglobin content as high as about 17 to 19. So they have a greater RBC volume. And the lifespan of RBCs in newborns is 90 days versus 120 days in adults. And the lifespan becomes even shorter in preterm babies. So that's why there is a rapid turnover of the RBCs resulting in hemolysis and production of more bilirubin, predisposing them to physiological jaundice. Now, the enzyme which is UGT1A1, which conjugates the bilirubin, is again immature in newborns and takes about 3 to 4 weeks for the maturity to reach the adult level. So within the first few weeks of life, the neonatal liver is immature, and that's why the conjugation is impaired. And third is higher enterohepatic circulation. So intestinal beta glucuronidase breaks the conjugated bilirubin into unconjugated bilirubin, which then gets reabsorbed into the bloodstream, resulting in enterohepatic circulation. There's decreased gut bacteria, poor gut motility, impaired feeding in the first few days of life because of decreased milk output. There might be an issue with the bonding of the baby and the mother. There might be some separation for whatsoever reason it is. And again, feeding practices, probably it takes a little time for the mother to get used to how feeding needs to be done. So all of these things combined can lead to increased enterohepatic circulation, where the bilirubin, which is supposed to be excreted out of the body, still stays in the circulation and can predispose to more jaundice. Under the same headings of increased bilirubin production, when there's any kind of incompatibility, either ABO or RH. Other cause of hemolysis like RBC enzyme deficiency like G6PD deficiency or pyruvate kinase deficiency. RBC membrane defects like hereditary spherocytosis, sepsis, torch loop of infections, and collection of blood in the body like a hematoma or subgaleal bleed, which can over time result in the breakdown of those RBCs in the collected blood, resulting in hemolysis and jaundice. So all of this falls under pathological causes where there's increased bilirubin production. Similarly, when the UGT1A1 enzyme, your conjugating enzyme, is either deficient or absent, like in Gilbert and Crigler-Najjar respectively, again, that will predispose to jaundice of pathological cause. And for increased enterohepatic circulation, you have two types of jaundice called breast milk jaundice and breastfeeding jaundice. We look at what is the difference between the two, which is more common, and what is the pathophysiology of both in the coming slides. But just keep this in mind that these are all causes of pathological jaundice. So now coming to the clinical examination, first is a general look of what the patient looks like. So whether the baby is awake or asleep, what is the activity like? So whether the child is having good activity, spontaneous limb movements, or is the child lethargic, looking hypotonic, looking sick? That will give you an idea of how sick the baby is. Next is cry. So whether the cry is vigorous or is it shrill? Is it a weak cry? And what is the posture of the baby? So normally a newborn would be flexed at the upper limb and the lower limb. That's a normal position of a term baby especially. You might have incomplete flexion in a preterm, but let's concentrate more on what is commonly seen like a term baby. So normally you will have flexed limbs, but if the baby is either hypotonic, then you will not see that posture. Or if there's any kind of opisthotonus, irritability, cyclical movements, all of this will point towards the fact that the baby is sick and needs urgent intervention. Okay, so this is what a general examination or a general look of the baby at the bedside will tell you. All of this is important because it will probably give you a hint of whether there are signs of acute bilirubin encephalopathy or not. So there's something called as a bind score that we'll be discussing. And all of these observations that you make under posture, cry, activity, etc., is scored in the bind score to tell you whether there's mild, moderate, or severe acute bilirubin encephalopathy. Okay, so we'll see that soon, but that's just an overview of why this general examination is important in a newborn jaundice case. Next is vitals. Like any other case, you look at temperature, pulse, respiratory rate, and CRT. So if there is dehydration, excessive weight loss, then you'll have poor peripheral pulses and a delayed capillary refill time. So again, if there's poor feeding resulting in weight loss, significant weight loss, delayed passage of meconium, all of this again as a vicious cycle exacerbates the physiological jaundice. And that's why establishment of breastfeeding at birth is excessively important, because not only does it prevent jaundice, but also prevents a lot of other complications like hypoglycemia, improves the bonding between the baby and the mother, improves milk output, and etc. There's a long list. But yes, establishing good and correct breastfeeding practices from the very beginning does help in curtailing your risk of newborn jaundice. Next is anthropometry, so birth weight, current weight, so you'll be able to tell what is the percent weight loss. So significant weight loss is up to 10% in a term baby and up to 15% in a preterm child. If the weight loss is more than this, then it is considered to be pathological and needs to be evaluated. Okay, if there is significant weight loss, again, it exacerbates jaundice, and that's why your difference in the birth weight, current weight with the percent weight loss becomes important. Usually, term babies regain their birth weight by 7 to 10 days of life, and preterm babies regain birth weight by about 2 weeks of life. If they haven't, then they need to be evaluated. Okay, so that's the significance of anthropometry in this case. Next is pallor and icterus. Now, what we really want to emphasize on is examination of icterus. But before I go into Kramer's and the other things, I'll just quickly mention that often looking at pallor when there's associated icterus might be a little difficult in newborns. The reason being, we don't look at pallor in newborns in the subconjunctiva because a lot of newborns usually keep their eyes closed, and we're not supposed to forcibly open their eyes just to look for pallor. Okay, and when there is icterus, which means a yellowish discoloration on the skin, it's difficult to appreciate pallor at the same time. And that's why it's a little tricky to mention examination of pallor when you're looking at icterus. But yes, icterus is something that you will be able to assess, and you have to assess, especially if you have a newborn case. And visually, you assess for icterus using the Kramer staging. So let's look at a little history of where the Kramer staging came from. How do you use it? What is the thought behind it, and what are the advantages and disadvantages of using a Kramer staging? It was Kramer who came up with this idea in 1969. This is a paper published in the American Journal of Diseases in Children. Okay, where he concluded that a positive relation between the serum bilirubin and the caudal progression of dermal icterus exists. So that means there's a craniocaudal progression or spread of jaundice. So jaundice starts from the head and starts moving towards down towards the extremities as it becomes more severe. And they were able to conclude that simple skin examination or simple skin inspection can give you information on the actual serum bilirubin level. Okay, so this was what was concluded at the end of the paper. And this study, which was published in 1969, we still end up using Kramer staging for clinical examination bedside even today. Again, there are a lot of advantages, disadvantages, pros and cons for this. But yes, it's been something that we've been using for like more than 50 years. And, it's Kramer who gets all the credit for this. So how do you do Kramer staging? First and most importantly, you have to examine the patient in natural daylight. No under the tube light, no halogen lights, no yellow lights, because all of them will give you a false inspection or a false assessment, because it's something that you have to see with the naked eye. That's why always take the baby to the window and examine the baby in natural broad daylight. Now, it was Kramer who concluded that jaundice progresses from the craniocaudal direction. Now, again, there is no explanation as to why this happens. There are a lot of theories. I won't really go into details of that. But yes, for sure, jaundice does progress in the cephalocaudal direction. Now, what are Kramer staging? So there are 5 zones, zone 1 to 5. So how do you do Kramer staging? Okay, so what you do is you blanch the skin at bony prominences at the midline of the body. So you start with the sternum, then the nose, then the chest or the sternum. Then you can blanch the skin on the abdomen, the thighs, legs, and then the palms and soles. Okay, that's because you want to see if the jaundice is progressed in the cephalocaudal direction. Now, what do you see when you do this or when you blanch the skin? So what happens is when you blanch the skin or you put pressure over these prominences, you look for staining of the skin and the underlying tissue. Now, basically, there are 2 pigments present in the skin, which is your hemoglobin, which appears red, and the bilirubin, which appears yellow. So when you're putting pressure and you blanch the skin, the hemoglobin gets displaced because your blood gets displaced to the side. And what you can visually inspect underneath is the yellowish discoloration of skin if there is evidence of jaundice. Okay, so that is the logic behind using Kramer staging and how you use it. Now, it is Kramer who divided the zones as 1 to 5. 1 is involving the face, 2 is up to the abdomen, 3 is up to the thighs, 4 is lower limbs and the arms, and then 5 is palms and soles. Again, zone 5 is the most severe. It almost corresponds to a bilirubin of more than 15 milligrams per deciliter. So that's why if the jaundice involves the palms and soles, it's always considered as pathological. Okay. So according to the latest recommendation by the American Academy of Pediatrics, they recommend that all infants should be visually inspected for jaundice at least every 12 hours following delivery up until they get discharged. So every 12 hourly, all infants should be visually inspected for jaundice till they get discharged. Okay. So this was how Kramer came up with this idea, and this is something that we still do bedside and is pretty helpful. But it's important to remember that the accuracy of Kramer staging reduces after not hemoglobin, what I meant is bilirubin. After bilirubin is more than 15 milligrams per deciliter. You cannot use Kramer staging after the child has received phototherapy. Again, the accuracy is poor in infants less than 35 weeks of gestation. And if the baby has required phototherapy, again, you can't use Kramer staging. And first 24 hours of life, also studies have shown that the correlation between clinical inspection and serum bilirubin is not that significant or relevant. So these are a few drawbacks of using Kramer staging. What we encounter most commonly is after the child has received phototherapy. So what happens is once the baby has received phototherapy, the skin gets bleached, and your visual inspection by blanching the skin doesn't really work because the skin has got discolored itself. Okay, so after receiving phototherapy, if you want to look for bilirubin levels, you have to send your serum or blood samples to look for total bilirubin. Okay, so these are a few caveats or drawbacks of using Kramer staging. And it was Kramer himself who had concluded that visual inspection of jaundice cannot replace the importance of laboratory investigation of serum bilirubin. Okay, so yes, we do use this test in and out bedside, but yes, you have to also keep in mind that this is not a foolproof method of uh, estimating your bilirubin levels. And higher the bilirubin, you should always correlate it with your serum bilirubin levels. And again, after receiving phototherapy, you cannot use Kramer staging. So moving ahead with the examination, going to head to toe, I'll only discuss the points which are relevant in a case of newborn jaundice. All the other head to toe examination that we've discussed in a normal newborn will remain the same. So first is you look at the anterior fontanelle and the posterior fontanelle. The size, if it's excessively open, it'll also give you an idea of your dehydration or the hydration status of the patient, which like we discussed, along with poor peripheral pulses, decreased CRT, let's say the AF is sunken, the child appears dehydrated, hypovolemic, again, that increases the chance of jaundice. Now, next is you look for any scalp swelling. Why is this important? Because cephal hematoma or any excessive collection of blood in the body can again increase your chance of jaundice. So then when you have a baby with a scalp swelling, what are your differential diagnosis? It could either be a cephal hematoma or a caput succedaneum. So how do you differentiate between the two again? Viva question, MCQ, clinically relevant. So we'll go over the difference between a cephal hematoma and a caput. So basically, cephal is a collection of blood under the periosteum, whereas caput is more a fluid collection above the periosteum. Okay. So when you talk about cephal hematoma, it appears within the first few days after birth or a normal delivery or a forceps delivery. So it's not usually seen at birth. It takes a few hours or days for it to develop. It's well defined by suture lines and gradually develops a hard edge. It's soft and does not pit on pressure. It becomes largest after birth and then tends to disappear by about 6 to 8 weeks or even a few months. because the underlying swelling is a collection of blood. When that RBCs undergo senescence and hemolysis, it will in turn release hemoglobin, which gets converted to bilirubin, so increased chance of jaundice. So that's why a patient or a baby who has Kefal hematoma requires more intensive monitoring when it comes to looking for jaundice, whether you do it clinically or whether you send a blood sample for serum bilirubin. But yes, a baby who has Kefal hematoma should always be kept closely under observation to look for development of jaundice. There is no specific treatment that you need to give for a Kefal hematoma. It's not that you have to drain it or there's anything else that needs to be done. It is something which will get resolved as time progresses. But yes, you have to keep them under observation to see if they're developing jaundice. So that's the difference between a capute and a Kefal hematoma, which you need to differentiate clinically, as well as to see which one has a more or a higher risk of developing jaundice. And other scalp swelling that is more dreadful is a subgaleal hematoma. So because the subgaleal bleed lies under the galea aponeurotica, which is a loose connective structure, if there is bleeding which extends into the subgaleal area, there is no bony structure to limit the collection of blood, so tends to spread all over, and subgaleal hematomas can extend almost up to the neck as well. So they lead to a lot of accumulation of blood, which again can undergo hemolysis, release bilirubin, and cause severe pathological jaundice. So subgaleal hematoma is another bruising or excessive blood accumulation that increases the risk of jaundice. Next, clinically, you look for dysmorphic features. So few syndromes associated with jaundice. One is Downs. We all know the phenotypic features of Downs, so I won't discuss that. Other than that, congenital hypothyroidism again increases the risk of jaundice. So if you have a newborn with suspected congenital hypothyroidism, they will have poor feeding, hypotonia, macroglossia, or a large tongue, large fontanelles, coarse facial features, coarse cry, delayed passage of meconium, umbilical hernia. And this is what a coarse facies looks like. Okay, so these are two syndromes that you need to keep in mind, particularly when you're looking for dysmorphism, because they both increase risk of jaundice. Why do kids with Down syndrome have increased risk of jaundice? One is they have a higher RBC cell count, higher hematocrit hemoglobin content, which increases the risk of breakdown of the RBCs causing jaundice. They have hypotonia, poor feeding, which increases their enterohepatic circulation. And there is a small component of hemolysis in those with Down syndrome. Whereas on the other hand, jaundice and hypothyroidism can be either conjugated or unconjugated or just both. In hypothyroidism, there is decreased activity of the UGT1A1 enzyme. So there's decreased conjugation of bilirubin. They again have hypotonia and poor feeding, and reduced gut motility, delayed passage of meconium. Again, all of this increases the enterohepatic circulation, predisposing to jaundice. One more clinically relevant examination is your torch infection. So when you have torch, along with jaundice, you'll also look for microcephaly or a small head, cataract, hepatosplenomegaly, skin petechiae, or hemorrhages. All of this can point, obviously, in a small for gestational age baby, all of this can point towards the underlying torch infection, which is also causing jaundice. So once we're done with the clinical examination, general examination, let's move with the systemic one. So two systems important for examination perspective in a case of newborn jaundice is the CNS and GI. Look at CNS first. So you look for the consciousness of the baby is alert and active or lethargic, sick looking. You look for cry and symmetrical spontaneous movement of all the four limbs. In the motor examination, you look for power and tone and posture, obviously. So posture, normally a newborn will have flexion of all the four limbs. If that's not the case, then again, you look for whether the limbs are extended, what is the level of extension of the limbs, and what is the tone like, whether the child is hypotonic, hypertonic, whether the child is having opisthotonus, rigidity, what is the scenario like. And last but not the least, quickly look for cranial examination and neonatal reflexes. So when I talk about uh, these examinations in the CNS, what I'm trying to look for is signs of bilirubin encephalopathy. So there's something called as the bind score, which assesses whether the encephalopathy is mild, moderate, or severe. So you look at three parameters: cry, tone, and mental status, and you score them from 0 to 3, depending on how severe it is. And then when you sum up the score, you get a mild, moderate, or severe grading of bilirubin encephalopathy. So if you look at mild, which is grade 1 to 3, they'll have a high pitched inconsolable cry. They'll be sleepy with poor feeding and mild hypotonia. Whereas in moderate encephalopathy, they'll be more irritable, or they could also have lethargy with poor feeding, hypertonia alternating with hypotonia, retrocollis, opisthotonus, and shrill cry. And then in severe, they'll have persistent opisthotonus, apnea, seizures, semicoma, or coma. So this is what the scoring system looks like. You score them from 0 to 3, and then you sum this up to get a total bind score. This is just an example that I took from research and reports in neonatology, wherein it's showing different stages of the encephalopathy. So if you look at the A and B picture, the baby is anxious looking. There is paralysis of upward gaze with lid retraction. So you can look at the upper end of the sclera, Collier sign with facial dystonia. In C, there's bicyclic windmill movements of the upper limbs. And then in D, there's neck retraction, opisthotonus, and scissoring of the lower limbs. So this is how encephalopathy progresses from mild to the severe stage. And it should be our aim that a child should never be able to reach the stage where they're at a risk of developing bilirubin encephalopathy, because it's devastating. It can lead to long-term deficits, and we should be equipped, and we should know how to clinically look for jaundice and what needs to be done when you have a newborn with jaundice. So that's one of the main reasons why this topic becomes so important, because this is a very preventable complication. You do not want the newborn to reach a stage where they're at a risk of bilirubin encephalopathy. So what we saw was acute bilirubin encephalopathy. Another term that all of us are well aware of is kernicterus, or chronic bilirubin encephalopathy. So when there's permanent and chronic sequelae of bilirubin toxicity, where it gets deposited in certain deeper structures of the brain, like the basal ganglion, cerebellum, etc. These can lead to long-term effects like chorioathetoid CP, where they have chorioathetoid movements because of involvement of the basal ganglion, which is the main regulator of tone and movements. It can lead to sensory neural hearing loss, upward gaze palsy, and dental enamel dysplasia, like we can see in this picture. So these are even worse complications of encephalopathy, which are chronic, and again, they're going to be there forever. So that's why, again, this topic becomes super, super important. In GI examination, inspection, palpation, auscultation, like any other GI case, usually in a case of newborn jaundice, which is most likely the unconjugated jaundice, the GI examination will pretty much be normal. We do not expect to have any abnormal findings. However, having said that, you have to go over the entire process of what you will see in inspection, palpation, percussion, and auscultation. I have written down the points here. I am not really going into discussion of that. Yes, if you're looking at, or if you're suspecting it to be an obstructive or a direct jaundice, then yes, you will have positive findings on your GI examination, like you might have organomegaly, or you can have like a palpable mass, which is like a choledochal cyst or some kind of obstructive structure, which is causing the direct or obstructive jaundice. Yes, but if you're looking at torch infections, you can have hepatosplenomegaly in the GI examination. But otherwise, in other hemolytic causes, most likely you will not have anything significant on a GI examination. But yes, organomegaly is something that you should definitely look for, because you might have positive findings in that. Other systems would be normal, like an RS and CVS. So at the end of clinical examination, you will say your final diagnosis as a case of either physiological or pathological jaundice, with or without signs of encephalopathy, and if yes, then what is the bind score? And then what do you think is the most likely etiology of the jaundice? So these are the three sentences that you will give at your final diagnosis. Before diagnosis, you will quickly summarize your case. So you will mention all your chief complaints and your positive findings on examination. And then after summary, you will give your final diagnosis. So I hope the clinical examination of newborn jaundice is clear. If you have any questions, any comments, any suggestions, you can note it down in the comment section below. I will put a link as well for this presentation so you can have it for your reference. And stay tuned for part 3, which is going to be a rigorous discussion on investigations, treatment, theory, MCQs, and Viva questions. So thank you guys for watching the video. I hope you liked it. I hope you found it helpful. Share it with your friends, and hope to see you soon with the part 3 of this series. Thank you once again.